Thanks so much. It's been such a pleasure to be here. I've learned a lot today. And I have the also rare pleasure and challenge of wrapping this up with, I believe, the last talk. And so I think actually that's a great opportunity for me. So arguably I know less about mental health research than anybody in the room. But the work that we do is more universal across biomedical research. And I think as I go through these initial slides, I can use it also to sort of wrap up what I heard echoed from many of you today, which is that clinical research is done because we're all seeking to improve current standards for clinical care. However, human health is really complicated. So we've heard today that diagnoses are imperfect, they're symptom-based, symptoms fluctuate and are dynamic and are heterogeneous across individuals. And so our ability to really try to understand health is very much confounded by that. The tools that we use, the set of tools that we use, is arguably incomplete. These statements are true today. They could have been true 15 years ago. They were true 15 years ago. If you close your eyes and pretend it's 2003, I could be talking about expression arrays and how they have been added to our toolbox and are going to help change our ability to look at research. In fact, I picked 2003 because that was the year I did my first expression array. And I can tell you that I ran a really poor experiment that was underpowered, and the batch was confounded with phenotype, and I used really rudimentary analytical approaches to try to understand that data. And that was because it was a new and emerging field, and nobody really understood what you needed to do to try to use that data effectively. And so here we sit today talking about digital approaches, digital phenotyping. And there's, two basic areas where I see this really occurring. And one is extending existing evaluations that currently or previously could only be done in the clinic, out of the clinic and into a real-world setting. And this provides us with a great opportunity to understand the nuance of those measures in real life. And the second is the ability to design completely new evaluations that we've never considered before based on the existing technologies that are now around. Both of these hold great promise, and as with the expression array example, both of them are requiring us to really think about how we're going to effectively use these technologies. As you heard, I work at Sage Bionetworks. We're a nonprofit research organization that thinks about open systems and how it is that while each of you are individually thinking through many of these problems, in fact, there's great ways where we can think through them and learn about them together that will be more effective, move us faster, and perhaps get us even further. And so the motivation is that, indeed, the scale and scope of data that we need to do this kind of work is immense. So perhaps if we share, we can start to catalyze that. The best practices for these analyses, completely unknown. And the only way we're going to be able to start to understand those is to collaborate, to provide our analytical outputs in transparent manners so we can evaluate that which each other is doing and start to come to some methodological standards within the field. And then the third is to listen to our patients or our research participants because they understand their disease and they can help inform the research that we're doing. So Sage got its start in genomics and it moved into mobile health about 4 or 5 years ago, and our general principle in both of those fields has been twofold. First, to build generalizable software that's built with ethical considerations in mind to allow anybody in the research community that wants to start working in more open ways to do so. And then the second is to partner with groups of researchers who are interested in testing out open methods together to catalyze those sorts of interactions. And so as we moved into mobile health, we're focused on smartphone-based research studies. We build a series of generalizable systems that anyone can use. The first was an electronic consent process that's now been used across many dozens of research studies to allow participants to effectively and informedly enroll in a remote research study. The second is a technical back-end platform, so luckily you now all know exactly what that is, that allows researchers to deploy these studies into apps and collect the data in a secure fashion. And then the third is a research platform that's actually used for researchers to collaborate, aggregate, organize, and share their data. And that's actually the Synapse platform, which we've actually been using in the field of genomics to do that sort of collaborative research work for many years, and we've now adapted to mobile health research as well. Because we were a partner in the original research kit launch, we've had the great fortune of testing this entire pipeline in more than 100,000 individuals, and so we're able to understand where it works and where it doesn't, and where we can build on it and improve it. And again, because of that, we're also able to look into the specifics of research studies that have operated through the system to understand commonalities across them in where this sort of research works and doesn't work and needs to be improved on. And so, the first general observation I can tell you is that indeed moving to a mobile research study allows us to expand the breadth of participants that we can study. We're not confined by individuals who live near a major research center, and we're able to get a more generalized view of disease. And in fact, in many cases, this makes participants feel as part of a community and more engaged themselves. The second thing we did was to use this approach to give a little bit of agency back to research participants to say, your research data is being collected by a group of investigators. Would you like that data to remain with those investigators or to be shared broadly with qualified researchers around the world who might be interested in using it for their own research? And we found that the majority of people were in fact interested in that. It's, I think, probably no surprise that a participant is taking the time to contribute their data and therefore wants it to be as effectively used as possible by as many people as can use it. So we also took the opportunity to get a little bit closer into the research study themselves. So we sponsored Empower, which is a research study of Parkinson's disease that used this approach, and enabled us to understand a little bit more closely how such things are effectively done. And so the premise of Empower was as follows. Research participants would download the app, and they would be given a series of opportunities for how they wanted to interact with the research study. So they could take a series of surveys. They could perform structured activities. These were the kind of activity that a Parkinson's patient may be asked to do actually by a clinician in the clinical setting, like a simple gait and balance test. Or they were asked whether we could collect passive data from them through their phone. And what you can see on the right in the number of tasks is that by and far the vast majority of people were interested in the structured activities as the way that they preferred to interact with this particular system. And so while we did collect some survey information and some passive data, but really what we found was these recurring activity tasks were the place where the most data was collected. Okay, so what are these tasks? So here's a series of tasks that we asked individuals to collect, and you can see listed below them the number of individuals who decided to perform one of these tasks and the number of total tasks we got across all of those individuals. So by far, the most popular task was the tapping task. This is very simple. Take your phone, tap back and forth for 20 seconds. This gives us some indication of motor initiation in Parkinson's disease. As I said, the passive data was the least interesting. We did have a memory test in there, but in fact, it was designed in a way that required an accuracy in motor coordination that most Parkinson's patients did not have. And so it did not measure cognition. It actually measured motor skills. And so we collected this data for 6 months, and then we packaged it up and it curated it. And the same day that we handed it to our internal analysts, we put it into the public domain under a controlled access program that was tied back to the original informed consent and made the data available for researchers around the world. And this was really important to us because this is early in its kind data, maybe not first in its kind data. And while we're trying to make sense of the data ourselves internally, we know that there are many other people in the world who are thinking about using this kind of data in their own research studies who would value the opportunity to understand what it might look like, because we know that there's going to be confounds in this data and complications to this data that we haven't figured out yet as a community, right? And at the time, I had 1 analyst. I now have 5. I'd like an order of magnitude more, but more importantly, I can learn about this data by the people using it outside of Sage just as much as I can learn about it from the people inside. Internally, we did some standard feature extraction and started to take a look at what the data could and couldn't tell us. And so I'll just take you through a couple of quick examples of what we found. So for the tapping test, which I already described to you, we were able to first show that the outcomes of this test were in fact correlated with standard in-clinic measures performed in those same individuals. But second, we're able to start to see some detail in the mobile test that actually clinicians weren't picking up. And that's because the data provides us with an objective rather than a subjective evaluation. And so the heat map I'm showing you is actually for those individuals that were showing a medication effect, a daily medication effect, in which their tapping changed before versus after medication. We could see that tapping was affected in 3 major areas. For some people, it was the speed in which they could tap, so that was the number of taps. So for some people, it was drift, so rather than pushing down accurately, they're sort of drifting across the screen. And for some people, it was fatigue, which is to say that they couldn't keep up a constant speed through the entire activity. And so we're able to start to see nuance within this very simple task that suggests to us that there may be more accurate sort of subphenotypes to consider that are now available. So as we've gone through analyzing this data over the last year to year and a half, we've run into a whole series of methodological challenges. And I just want to highlight that here, which is to say, if you look at the data, which is over on the left, what you're looking at is individual participants. The yellow ones are cases, and the green ones are controls. And you're looking at repeat measures for doing this same test over and over again. And what you can see is that there is a high amount of individual variation that has nothing to do with disease in this example. And that's actually true for a lot of the digital measures that we're looking at through the phone. It's not that there isn't an effect of disease or treatment or intervention within the data, but that it's highly confounded by that individual effect. And this means that you need to take that into account when you do your analysis. And so what I'm showing you on the right is that if you take this same data and simply change the way that you split it into a training and test set and run the exact same machine learning algorithm on it, you can get an AUC of 0.43 or of 0.89. So arguably one of these is underfitting and one of these is gloriously overfitting the data. And so we as a community need to understand this. We need to evaluate each other. There needs to be transparency in what we are each doing so we can come to some accord as to what the most effective and correct ways to treat this sort of data may be. So one thing, as we lifted our heads up from the tapping data, we started to look around at the other kind of data that we were collecting, one of which is this gait and balance test I was telling you about. And what we realized was that we internally did not have, no surprise, the expertise as a group of genomic researchers to think about accurately processing accelerometry data. And so we were not doing very well with this kind of data in terms of disease classification. However, we knew that there are many people out in the world who are both interested in this kind of data and have better skills at that than we do, including perhaps some of the 115 people who have downloaded the data from our site. And so we reached out to those 115 people and asked how many of them might be interested in working with us to understand the most effective ways to do signal processing on this data. And so here's a list of the individuals who were in fact interested. So I will note that 3 of the groups on this list are building their own devices to capture accelerometry data in Parkinson's disease patients, right? So they're using our public data to try to get an early understanding of what this what this data looks like for the purposes of helping their own research. It makes perfect sense, right? And so they were interested in working with us and collaboratively all together to see if we could figure out the best way to address this data. And so in the span of about 3 weeks, and with one turn of the crank, we collectively were able to have about a 10% increase in our AUC, which is, I'm showing you there, and admittedly, those are still terrible. That's fine, because we decided that this would be a more effective experiment if we then expanded it to the rest of the research community. And so this summer, we ran an open, crowdsourced dream challenge that asked anybody in the research community interested in this question to join us in trying to find an appropriate solution. And this started in July. The last final feature selections were, I think, last week. And what I can tell you is we haven't announced the winner yet, so I can't tell you the actual results, but I can tell you that they blew us all away. And so now all of these groups and all of the researchers that were involved in the challenge, and actually anybody in the research community, will have this objective, benchmarked evaluation of feature processing on accelerometry data that they can take forward and use rapidly in their own efforts. So as I wrap up, I'll say just a couple of extra things, which is one thing that we haven't done as good a job as we can at yet is actively engaging our participants throughout the process of research. We know that from listening to our participants that they see daily fluctuations in their disease. We know the things that they themselves find actually affect those fluctuations, and we now have a system where we can start to measure those effectors relative to symptoms of disease and bring them together. And that's, in fact, what we're looking to do in the next round of this project. One additional note, everything that I've been working on thus far, and much of what I've heard everybody talking about today, has really been focused on individuals in diseased populations. And those are highly motivated individuals. And even their engagement is low for these sorts of remote evaluations. When we think about moving into healthy populations and using these sorts of approaches to try to understand sort of health trajectories outside of disease, pre-symptomatic evaluations, we're going to have those problems in spades, right? It's going to be even harder to motivate individuals to get involved and to engage them in this process. And so we have the honor of being a part of the All of Us research program, which is starting to address some of these problems. I know that many of you are thinking about this as well. And I think that this is an area where if we don't come together to try to understand how best to affect this, it's going to take a really long time to answer this question. I guess just in summary, I think that the intersection of technology, ethics, appropriate data governance, and science is a really exciting place to be, and it's necessary for us all to come together to figure out how to solve these problems.